Pediatric keratoconus: diagnosis and treatment. In this class, we will discuss about background and pathophysiology of keratoconus and pediatric keratoconus, diagnosis, differences between pediatric and adult keratoconus, a spatial entity, Down syndrome and keratoconus relation, treatment options, in particular corneal collagen cross-linking. An extensive literature review from 1 year to 10 years in pediatric cases. Finally, conclusions and take-home messages. This pathological section is important for showing the nature of keratoconus. Keratoconus is a progressive and asymmetric disorder with stromal thinning, irregular astigmatism, high myopia, and decreased vision. And pathogenesis of keratoconus: genetic mutations and environmental factors such as eye rubbing and atopy play important role. These factors lead molecular changes in cornea, such as extracellular matrix degradation, oxidative stress, and inflammation. Histopathological changes can be observed in epithelium and stroma. Finally, biomechanical property of cornea changes and get weakened. In diagnosis of keratoconus, a detailed patient history, complete ophthalmological examinations including dilated retinoscopy are mandatory. Corneal topography or anterior segment tomography devices are also important. Corneal epithelial maps gained popularity in recent years, in particular in early cases. We can also measure corneal biomechanics in diagnosis of early keratoconus. There is an important question: when does keratoconus start? According to the current evidence, mechanisms start at puberty, but clinical manifestation is commonly in the second decade of life, especially prior to the corneal refractive surgery. We should also mention about relation between Down syndrome and keratoconus. Patients with Down syndrome more likely to represent corneal morphological abnormalities and higher incidence of keratoconus. However, data regarding frequency of keratoconus in patients with Down syndrome is highly changeable. It changed from 0% to 75%. A case report documented keratoconus eye drops as early as 4 years of age in a child with Down syndrome. A detailed corneal workup is mandatory in Down syndrome to detect keratoconus earlier, and immediate treatment should be performed. Does keratoconus behave same in pediatrics and adults? The answer is no. According to the current evidence, weak ectatic lamella exceeds the capacity of age-related natural crossing process in pediatric keratoconus. These cases show more rapid progression, and they also have 7-fold higher risk of needing corneal transplantation. Atopy and vernal conjunctivitis are important, and they are related with faster progression and long-term complications. Unfortunately, at diagnosis, keratoconus is more advanced in children. In summary, 30% of children and adolescents have stage 4 keratoconus at diagnosis. 88% of pediatric patients show corneal stiffening greater than 2 diopters within 1 year. Unaffected eye develops keratoconus in 35 of cases, and we cannot predict timing. An important trial showed that age between 10 to 20 years is an important predictor of significant progression and corneal scarring. Conventional treatment modalities are on visual rehabilitation in patients with keratoconus. However, only therapeutic option is corneal collagen cross-linking. Standard EPO cross-linking procedure, also named as Tristan protocol, includes removal of corneal epithelium, topical administration of riboflavin solution, and irradiation of cornea with UVA for 30 minutes. In 2003, Wolenczak and colleagues presented corneal collagen cross-linking as a new hope for treatment of keratoconus. They showed that this procedure stops keratoconus progression and increases biomechanical stability of the cornea and resistance to enzymatic digestion. What's the mechanism of action of this procedure? Combined application of UVA and riboflavin causes production of oxygen radicals in the stroma. These radicals induce collagen crosslinks between collagen fibers. More cross-linking leads stronger cornea. In this image, you can see a cross-linked cornea which resists gravity. Ten-year outcomes of corneal collagen cross-linking treatment was published. It was shown that this procedure is effective and safe in adult cases with keratoconus. What about this treatment in pediatric cases with keratoconus? This figure belongs to a child with bilateral corneal hydrops. We want to emphasize the necessity of ocular assessment in atopic children and necessity of urgent treatment in this photo. Let's take a look to the current literature on pediatric cases with keratoconus and collagen cross-linking treatment. One-year outcomes of cross-linking treatment in pediatric cases with keratoconus showed that this treatment was effective, improving uncorrected and corrected distance visual acuity and flattening in apical keratometry, with no significant complications. When we look at two-year outcomes of this treatment in pediatric keratoconus, this treatment was also effective at 2 years, improving corrected distance visual acuity, flattening in maximum keratometry, and improvement in keratoconus indices. These two figures shows improvement in corrected distance visual acuity and maximum keratometry. Pinjigero and colleagues presented 2-year outcomes of this treatment in pediatric cases. According to this study, all keratoconic eyes were stabilized, and distance visual acuity, keratometric indices, and higher order aberrations were significantly improved. Also, no significant complications were observed. Endothelial cell density wasn't altered at 2 years. Three-year outcomes of cross-linking treatment in pediatric cases was in agreement with previous studies. However, an important study by Chatzis and Hafazi showed that pediatric cases with keratoconus show 88% of progression. They also suggested that significant maximum keratometry reduction observed up to 2 years lost its significance at 3 years. In conclusion, they suggested to perform cross-linking treatment as soon as possible diagnosis is made. They also concluded that arrest in keratoconus progression might not be long-lasting. In their study, one of a patient with persistent eye rubbing required retreatment. On the contrary, Uchakan and colleagues presented 4-year outcomes of cross-linking treatment in pediatric keratoconus. They reported no change in mean endothelial cell density and no progression, as well as improvements in visual acuity, topographical indices, and maximum keratometry. After 4 years from treatment, some of the studies reported decrease in efficacy. A study reported that after 4 years, 24% of eyes showed steepening and nearly 31% of eyes showed reduction in visual acuity. These two tables show decrease in efficacy regarding corrected distance visual acuity and maximum keratometry across the time after treatment. Ten-year outcomes of cross-linking treatment in pediatric keratoconus was released. According to this study, corrected and uncorrected distance visual acuity improved. Keratoconus stability was recorded after 10 years in nearly 80% of the patients. The overall 10-year follow-up progression rate was 24%. In their study, 2 eyes of 2 patients underwent corneal grafting. On the other hand, according to the 10-year study, topographic surface asymmetry index lost its significance after 7 years of treatment. However, comma values improved from the beginning and maintained its significance during 10 years. This chart graph shows that maximum keratometry lost its significant improvement after 7 years of treatment. However, corrected distance visual acuity maintained its significant improvement after 10 years. What are the concerns about cross-linking treatment in pediatric cases with keratoconus? First concern is about safety of this procedure in pediatric cases. In vivo studies showed that 85% of UVA is absorbed by riboflavin in the anterior stroma. Also, endothelial cell count wasn't found significantly altered after treatment. Some of the authors suggest using limbal rings to protect limbal stem cells. Macrobial keratitis is a rare entity after both standard and accelerated cross-linking protocols in pediatric population. Although transient haze is a common complication, it's reversible. Transient decrease in thin spirometry might maintain up to 1 year. The second question is why efficacy of this treatment tends to regress over 3 years. It's related to corneal collagen turnover. Keratoconic corneas have an increased collagen turnover. Corneal remodeling after epi-off cross-linking procedure may delay collagen turnover period up to 2 years. It was shown that before 15 years of age, efficacy more likely to regress. After 15 years, age-related corneal natural cross-linking helps keratoconus stabilization. The other question is epi-off or epi-on cross-linking protocols in pediatric cases. There are various studies on epi-off procedure, and it was shown that it's effective and safe. On the other hand, studies on epi-on cross-linking procedure in pediatric keratoconus present conflicting outcomes of this treatment. For instance, one study by Magli reported that epi-on cross-linking was less painful and provides similar effectiveness with standard epi-off cross-linking at 1 year follow-up. On the contrary, Eraslan and colleagues showed that efficacy of epi-on procedure is nearly 70% of the efficacy of epi-off cross-linking procedure in pediatric cases. So, epi-on or epi-off cross-linking in pediatric keratoconus. Epi-on cross-linking has conflicting outcomes. So, epi-on cross-linking may be reserved for use in specific patient populations such as Down syndrome and other special situations. The other important question is standard or accelerated cross-linking procedures in pediatric keratoconus. There are some studies on accelerated cross-linking in pediatric keratoconus and reported promising results. These studies show that accelerated cross-linking protocols are effective and similar to the standard Dresden protocol. Briefly, recent studies on accelerated cross-linking protocols give promising results. But longer periods of exposure, such as 9 and 10 minutes, may provide more improvement according to these studies. Timing of cross-linking treatment in pediatric keratoconus is another concern. We know that pediatric keratoconus is more severe and aggressive. Nearly 20% of the pediatric cases need transplants. and 1-year progression rate of keratoconus is 88% in pediatric cases. So please don't wait to treat. Vernal keratoconjunctivitis and eye rubbing is very important. It's related to rapid progression and treatment failure. Please prevent eye rubbing for each case. This topographic image belongs to 14-year-old May with advanced keratoconus in his right eye. You can see advanced steepening in maximum keratometry and decreased vision. This patient underwent epi-off cross-linking procedure. At 1-year control, visual acuity was significantly improved and maximum keratometry was significantly flattened. Conclusions and take-home message. Consider keratoconus in pediatric subjects with rapidly progressing visual deterioration. Down syndrome-related keratopathy is an important issue and keratoconus incidence is very high. Perform a complete corneal workup and immediate treatment. Most importantly, pediatric keratoconus is so aggressive. Don't wait for progression to treat. Standard Dresden protocol is safe and effective, and now it's the gold standard method. There is tendency to lose efficacy after 3 or 4 years in pediatric keratoconus. Retreatment is possible and might be needed in cases with persistent eye rubbing. So prevent eye rubbing in pediatric cases. Epi-on and accelerated protocols. We need more evidence. Thank you for your attention.